Good morning on a rather damp St David's Day here in Cardiff.
Can I call Dr. Chris Williams, please?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Could you please start by giving us your full name?
Christopher Julian Williams.
Dr. Williams, thank you for attending the inquiry today to give your evidence. Can I just remind you to please keep your voice up so that we can hear you, but also so your evidence can be recorded. If I ask you a question you don't understand, please do ask me to rephrase it. There will be breaks, but if you do need one, let us know. Your witness statement to this module is at INQ 000251938. That was signed and dated on the 17th of August. And is that statement true to the best of your knowledge and belief?
It is.
Now, Dr. Williams, in terms of your professional background, I understand that you have worked as a consultant epidemiologist in Public Health Wales Communicable Disease Surveillance Centre, the CDSC, since 2013, and you've been involved in public health responses to communicable diseases since 2001. Is that right?
Yes.
You are a medical doctor. You completed your medical training and trained as a medical registrar with NHS England, following which you trained in the European Fellowship for Intervention Epidemiology in Germany. Is that right?
Roughly. There's some of the organisations have changed names, but yeah.
And between 2008 and 13, you worked as a consultant in communicable disease control with responsibilities for outbreak control and surveillance, and you had involvement, I think, in the 2009 swine flu pandemic. And in addition, you've worked for the World Health Organization as an epidemiology consultant. Is that also correct?
That's correct, yes.
Now, Dr. Williams, going back to January 2020 and setting the scene, at the time, you were one of only 3 consultants in the Communicable Disease Surveillance Centre. Is that right?
Yes.
Can you briefly tell us what the CDSC was and perhaps explain its importance and significance in that period, January to March 2020?
So we have a responsibility for surveillance of infectious diseases, also advising on outbreak management and research, teaching, those kind of activities. In the early part of the pandemic, we moved from hearing about the first case from the WHO at the end of 2019 to starting to get briefings, mainly through colleagues in Public Health England, about this new infection, new disease that was affecting people in China. And there were a series of meetings on that, which in general Public Health England led, and we were picking up on what was going on, and I was disseminating it through my organisation.
And we will come to look at that in a bit more detail and break that period down in a moment. But I understand that in March 2020, you became one of 3 incident directors to Public Health Wales. What did that role involve? So
that was more day-to-day decision-making, attending particular groups with respect to the response within Public Health Wales, and monitoring the situation. So there was quite a few tasks associated with that, but essentially it was the tactical response on the day. I was one, as you say, of 3, and then I think there were 4 later.
And I'm right in saying you were also involved with the technical advisory cell and the technical advisory group that we heard a bit about from Dr. Hoyle yesterday. Is that right?
That's right, yeah.
What was your primary contribution to the technical advisory group?
So at the beginning, I was involved with my role as an epidemiologist and passing on some of the information I was getting through the briefings and other mechanisms. I think the majority of the time I was there to give reports on the surveillance and the unfolding epidemiology of the infection in Wales.
Would it be a fair summary to say that you were fairly heavily involved then with Public Health Wales and the technical advisory group's pandemic response in that early period, January, February, March 2020?
I think that's fair to say, yes. Probably more Public Health Wales because that was my main role, but I was also involved in TAG and worked with the Chief Scientific Advisor for Health.
So you were working closely with Dr. Orford. Were you also working closely with Dr. Atherton, the Chief Medical Officer?
Less so with Dr. Atherton. It was more Dr. Orford.
And of the group of scientists at that time that were working and advising, was it only you that had an academic background in epidemiology and communicable diseases?
I can't recall all of the qualifications of everyone in TAG, but certainly Welsh Government colleagues were more health and health policy and other aspects of science. There aren't a huge number of infectious disease epidemiologists in general and in the UK.
And am I right in saying you undertook this work in an independent capacity insofar as you were not employed by the Welsh Government? That's right, isn't it? Now, when did you first become aware of the pandemic?
So I can't recall exactly, but I think I would have seen news reports of the WHO report at the end of 2019. I think it was the 7th of January when there was a briefing just after the Christmas period from Public Health England about a new pneumonia syndrome coming out in Wuhan in China. And there was sketchy information at that time, but there were continual meetings, repeated meetings, and then we started to learn more.
And following that 7th of January Public Health England meeting, what role did you assume regarding the outbreak?
Within CDSC, we tended to get involved when there was a briefing or some kind of communication about something that came through nationally. So I wrote a briefing note, I think it was the next day. Based on the initial briefing, I informed other colleagues, and I think there were further briefing notes that came out from England that we then read and adapted and added to.
Now, the inquiry understands that there was a devolved administration's update on the 15th of January that was also hosted by Public Health England. Did you attend that meeting? Can you recall?
I'd have to check my evidence pack. Probably I would have done.
What was your perception of the risk posed by COVID-19 at that time? So we're talking mid-January 2020.
I honestly can't recall what my perception is. What I do remember was that towards the latter half of January, as there were reports of more and more cases coming from China, I was attempting to work out how fast the infection was spreading using some very rough, mathematical techniques. So I must have been aware that there was a possibility of much wider spread.
And at this point in time, so still in sort of mid to late January, what body was responsible for providing expert epidemiological and scientific advice to the Welsh Government in a sort of day-to-day, de facto sense?
That would have been Public Health Wales. Public Health England, because of they had a larger respiratory department, an international department, and other links, they tended to get information earlier or from different sources to us. Obviously, we could access the media and other published sources, but a lot of the time we were taking information that was given to us by them, interpreting it, seeing what the context was for Wales, and then disseminating it within our organisation and also to Welsh Government.
Now, on the 23rd of January 2020, there was a Public Health Wales briefing entitled Update on Wuhan Novel Coronavirus. I don't intend to bring it up on the screen. I just want to understand, did you play a role in authoring that briefing?
Yes, I would have written that, but again, adapted probably from a Public Health England briefing.
Understood. Now, that briefing note confirmed the likelihood of human-to-human transmission, and just to read a passage from it, it says, due to the enlarging geographic area affected and evidence of human-to-human transmission, it is increasingly likely that suspected cases, those with an appropriate clinical picture and travel or contact exposure, will be identified in the UK, including Wales. Did that 23rd of January briefing change the pandemic response in any way in Wales?
Once again, I can't remember the exact sequence of events regarding the stepping up of various emergency response activities within Public Health Wales. But we were certainly, that briefing would have gone to key individuals within Public Health Wales, and we made sure that people were aware of the risk.
Can you tell us how Public Health Wales was monitoring and advising the Welsh Government on the spread of COVID-19 at this time? So we're still at the back end of January 2020.
Again, my recollection is not strong from this time, but where we would have had information from the England briefings and by that time daily meetings regarding the situation, I would have and sometimes colleagues would have sent out an email that also included, I believe, Welsh Government colleagues at the time. If it wasn't directly to Welsh Government colleagues, then someone more senior to me would have disseminated that.
Was there an understanding amongst your colleagues and those advising the Welsh Government at this time that this had pandemic potential?
I think we were beginning to realise it had pandemic potential particularly once there were more widespread cases in China. You don't necessarily get to hear about all of the cases and all of the transmissions, so you can probably assume that if there are actual official reports from a country such as China, that there's probably quite a lot of transmission going on, and there was still international travel.
Did you or any of your colleagues at this point think it worthwhile to review the Wales pan-flu response plans and look whether they would be sufficient for a coronavirus pandemic?
I can't recall whether we looked particularly at the pandemic flu plans. We would have been aware of them. As I said, I was involved in the 2009 pandemic, so I'm sure I'd have looked at them at the time. But the plans you have to adapt based on the circumstances that are coming, and I think this needed a different response.
Just on that point then, were you given, can you recall, any instructions at any point at this period of time to perhaps begin reviewing population-wide MPIs to deal with a virus spreading such as this, as was instituted in China?
So we had the example of China. I don't recall considering those for the UK. The climate of thinking was not necessarily to start with NPIs, because they'd never really been done at that level. That took a bit longer for that thinking to come through, I think.
What about scaling up surveillance and contact tracing capacity? Was that something that thought was given to at this point in time?
We were certainly scaling up surveillance activity. There were the first few hundred epidemiology forms that we were trying to complete where we got suspected cases. And in terms of contact tracing, I think I did, it might have been February by that time, I think I did write something on that. Contact tracing per se isn't necessarily the responsibility of CDSC, but we would have been involved in the surveillance and maybe advising on that kind of response.
And to your recollection, was there any work being done to prepare care homes and hospitals for numerous cases and the risk of nosocomial infection?
I can't recall any particular preparations along those lines, but we did make sure that all of our briefings went to the health service in Wales, and nosocomial spread of infections, respiratory infections, is always a risk, and yeah.
Now, Dr. Sandifer has told the inquiry in his written evidence that, with the exception of the CMO and his staff, he did not see the same awareness of and urgency about COVID across the rest of the Welsh Government. He has said what he thinks was missing in these first few weeks, namely 8th of January, when he first became aware of COVID, to the 20th of February, which was the first meeting of the Welsh Government SSG Coronavirus Planning and Response Group. He says what was lacking was national strategic leadership and coordination from the Welsh Government. Do you have any comments on those observations of Dr. Sandifer?
Between sort of mid-January up till sort of late February, early March, I didn't have an awful lot of direct working with the Welsh Government, so I'm not really able to comment on their level of preparedness.
Now, the inquiry's heard in Module 2 that the approach to the pandemic response, in accordance with the UK influenza pandemic strategy, was one of containment. What did you understand by containment, and how was that implemented by Public Health Wales?
The idea behind containment is that you would identify every single case that came into the country. You would trace their contacts, gather some information about them and their contacts, and put into place isolation and quarantine of those contacts to ensure that there were no secondary or further cases. That had been the response also in 2009 as containment phase, as they called it.
Now, the inquiry also understands that in January 2020, there were several direct flights each week to Wuhan City from London Heathrow and other indirect flight routes. We know also that the common symptoms of COVID-19 were a fever and a cold, so the kind of symptoms that might mirror a common cold might not give cause for concern. Knowing all of that, what was your view on the likely success of a containment strategy?
Again, I don't know exactly what my thoughts would have been at the time, but I had my experience of the 2009 pandemic of influenza, which showed that containment really isn't very feasible in a country with lots of international connections, with infections that are highly contagious, rapidly spread, and spread through multiple mechanisms.
Was it your view then, with that prior experience, that Wales needed to really start preparing for mass community transmission?
I suppose that's the implication, yes, that was probably on the way when we were doing, so I wasn't directly doing the contact tracing, but when we were responding to that surveillance-wise, I think we were aware that it wasn't going to be successful. And
perhaps with the benefit of hindsight, do you think that containment was the right approach for Wales in February 2020?
I think it was, because even if you think you're eventually not going to succeed, it's worth trying the best you can. It will at least slow, especially in the first few cases, you can genuinely slow the infection. But as more and more people travel, you get cases that you're not aware of that are then transmitting. Then that's when it becomes untenable.
As we move into late February, how did the epidemiological picture in Wales develop?
So I checked my notes before. The first case I think we reported was on the 28th of February in someone who'd returned from northern Italy. And then you should also remember that before that, there were a number of suspected cases reported. So people with appropriate symptoms and who had travelled to China or the changing list of countries who were then identified, isolated, tested and found to be negative. But this was our first positive case. And from then on, the case numbers did increase through March.
And a week or so before that first case, there was a SAGE meeting on the 20th of February. Were you and your colleagues at Public Health Wales appraised of what was discussed at that SAGE meeting? Can you recall?
I don't recall that particular one. I don't think I was able to have any contact through SAGE meetings until either late February or early March via Welsh Government colleagues.
So after that SAGE meeting of the 20th of February, Dr. Orford emailed Dr. Atherton and some other senior figures in HSG about those SAGE discussions. Now, you aren't copied into that email. It says, from cruise ship, 30 to 50% asymptomatic mild, likely that UK testing has missed 40% of positives due to delay in testing versus detectability of virus. Are those figures, and especially that point about testing missing 40% of positives, something that you were made aware of at that time?
I think I would have heard about the results of the cruise ship testing through some of the other professional briefings, and the fact of there being some asymptomatic cases probably wouldn't have been a huge surprise.
I mean, if 40% of positive cases have been missed, does it not follow that containment measures would effectively be obsolete?
That is the difficulty with containment. I remember writing things at the time saying if we're not catching all the cases, then you're only getting whatever effectiveness you get from the cases that you do know about.
So being aware of this figure of 40% being missed of positives, did you or any of your colleagues advise the Welsh Government of the difficulty that this presented with a containment strategy?
I don't recall any advice I gave on that respect. But the containment strategy, in my recollection, was a a kind of UK-led strategy. So we were following the UK strategy, which started with containment.
But if by the 20th of February you've got Dr. Orford emailing Dr. Atherton and noting in particular this worrying data about missed 40% of positives, should Wales have still been following the UK government containment strategy if effectively it was a doomed strategy by this point in time?
I would say that if you take the counterfactual, if Wales had decided that we would stop contact tracing, stop trying to identify new cases, whilst that activity continued in the other nations of the UK, I don't think that would have been particularly helpful to the response. I think you have to try, even though it's very difficult and essentially impossible after a while.
Can we please have a look at INQ 0003097114? This was a presentation that was delivered, as we can see on the screen, by Dr. Sandifer to the HSSG Planning and Response Group on the 28th of February. It provided an update as to the progression of Covid-19 in Wales. Did you have any input into this presentation, Dr. Williams?
I don't recall, but it's likely that I would have done through some of the update slides that we'd send around.
If we can please have page 16 of this presentation. The third and fourth bullet points read, estimated tenfold increased demand with further widening of geographical area within Europe, estimated 100-fold increased demand to account for historic cases that will then meet possible case definition. In this context, what does demand refer to? Is this the demand on Public Health Wales to conduct surveillance and containment on all likely COVID-19 cases?
I can't recall exactly, but I think there was a discussion about resources needed for contact tracing around this time, and that might have been playing into this. The contact tracing is very resource intensive, and with a sort of exponential increase in cases, it becomes quite difficult.
And did you agree that there was likely to be a tenfold and then 100-fold increase in cases that needed to be contained?
I can't recall this exactly. The second statement seems to be about changes to the retrospective changes to the case definition. So, yeah, I'm not sure that I can't remember the implication of this.
I mean, at this point, would it be fair to say it was almost certain that community transmission would become widespread in the event it wasn't already?
Yes, I think that's fair to say, and I say through my experience from 2009, I didn't think that containment and contact tracing was a possible early means of containing an infection like this, particularly in a country such as the UK, and when we had continued travel and continued movement within the country.
We can please look at the next page, page 17. So on this following slide, it reads, healthcare providers' response, future challenges, step change in magnitude of response required. So did you see the need for a step change in the magnitude of response once it was clear that containment would not last?
Yes, it was going to be a huge demand on the NHS, regardless of the impact on the individuals, also just the isolation, testing, those kind of demands.
Could we please have INQ 000252-365? Thank you. This is an email thread on the 29th of February, so the day after the presentation we've just been looking at, regarding Public Health England modelling work. We can see that from the subject title. It's an email chain between yourself, Andrew Jones, Deputy CMO, Quentin Sandifer, and Dr. Orford. Can we please look at page 2? And the bottom email is from Andrew Jones, who worked for Public Health Wales, to Dr. Orford. And it says, Dear Rob, we've just come off the PHE IMT. PHE have reported through Yvonne Doyle, MD, that work on the modelling to inform scenario planning next stage guidance, including on containment strategy, has been accelerated and will commence today. Then if we can just go up to the next email in the chain. So it starts on the bottom of page 1. It's an email from Dr. Orford in response, "Thanks, Andrew, this is very helpful. Please let me know if there's anything that you need from me in the interim. Happy to call if this is easier. We'll continue setting up a stack and work on better sharing of intel. We'll write to Sage early next week, informing them as such, including those involved. Once we have the secure shared drive and mailbox in place, we will forward details. Have not received readout from Thursday's Sage yet, which concerns me." And then the next email in the chain, the next one above, is from Dr. Sandifer in the middle of that page. "We should avoid calling it a stack. It isn't, and what we need is the same level of urgency as it seems is happening in PHE DHSC." Now, do you agree, Dr. Williams, that parts of Public Health Wales HSSG were not responding to the COVID pandemic with the same level of urgency as in Public Health England?
I don't think that was necessarily the case. You say Public Health Wales HSSG, so HSSG is a subgroup of the Welsh Government, is my understanding. But yeah, we were working certainly within the CDSC with a lot of urgency, and a lot of our work was directed towards this.
As we move into March, there was a COBRA meeting on the 2nd of March in which it was announced that contact tracing for the source of the last 2 cases of COVID in the UK had been unsuccessful, and that there was sustained community transmission in France and Germany. So at that point, was it not guaranteed that containment had failed?
Yes, I imagine so.
Now, there's nothing of this in the TAC minutes of the 2nd of March. Does that suggest that TAC had either not been made aware by its counterpart scientists on SAGE before that was announced in COBRA?
Don't recall the discussions in TAC. My recollection from the time is that particularly up until the first lockdown, we were really, as a UK, including Scotland, Northern Ireland, following a sort of UK government and PHE-led response. So containment was part of the overall response, and we could have had debate internally about whether it was working, whether the contact tracing was working, but there wasn't really a sense that was something amenable to change. This was the response, and even now, I think that was fair. I think a UK response was the right thing at the time.
So just going back to one of my earlier questions, when I think I asked you from your experience on the ground, who had overall ownership of pandemic response in this early period, I think you answered Public Health Wales. In light of what you've just said, would it not be fair to say that effectively ownership of pandemic response was being led by Public Health England, with the devolved administrations, we're obviously focusing on Wales and Public Health Wales, sort of effectively following suit? Is that fair?
For most of the major decisions, I think that was fair, but of course we had to plan within the context of a Welsh NHS and our own systems, and I know my colleagues in the laboratory, for example, were working on testing, etc. So there were elements that were Wales specific, but the overarching plan, I think, was a UK one.
I now want to turn to a SAGE report. It's INQ 00022470. It's entitled, as we can see on the screen, "Low critical care capacity and high severity of COVID-19 mean there is little functional difference between successful flattening the curve and ongoing containment." And this was presented to SPI-M and SAGE. It's, I think, first produced 9th of March, but then updated on the 16th of March. If I can please ask for page 6, final paragraph, to be brought up. And I'm going to start reading from the end of the second line. "The model results here do no more than reinforce the findings of the WHO China mission and validate the strategy adopted by Chinese health authorities in or around the 23rd of January 2020, and then subsequently by Hong Kong, Singapore, Japan and South Korea. We suggest that they are strong evidence with which to abandon mitigation strategies justified in any way by the possibility of a short epidemic. Governments need to devote the entirety of their attention and resources to creating viable ongoing solutions to the presence of this virus. We suggest that the first step is to adopt stringent fixed-term social distancing so as to give time for detailed planning, the rapid development of any accompanying technology." Were you made aware of this SPI-M paper And if so, when were you aware?
I don't recall exactly when I was aware of it, but I can recall it was within a few days, or maybe even the same day. My recollection is this represented a kind of shift in thinking in terms of the academic papers that have been brought to SPI-M from a strategy of mitigation, which was the flattening the curve, to a recognition that mitigation would actually be an untenable and catastrophic situation, and actually would probably result in the same sort of social distancing that a planned extreme social distancing by mandate would have done. So I think this Riley paper was the first one that really set, in my recollection, that said that we had to lock down essentially and soon, and that mitigation wasn't really a viable strategy.
So this was significant in shifting the opinions within TAG, is that right?
I think I can't say for within TAG as a whole group, but I think I had some indirect access to what was going on in SAGE, and I think SPI-M at the time, and this shifted the viewpoints there.
If we can please have INQ 000251994 on the screen, please. This is a TAC document titled COVID Technical Advisory Cell Briefing on Behavioural and Social Interventions. It was circulated on the 11th of March, 2020. Looking at the second paragraph first, please. There are a range of behavioural and social interventions that are evidenced as having been effective in responding to past epidemics. These interventions are well understood by the public and have been enacted in other countries. Then on the third paragraph, applying behavioural interventions could be helpful in containing an epidemic to some degree or changing the shape of the epidemiological curve. Just pausing there, why could be?
Yeah, I have reviewed this document. It does come a few days after the Riley paper, although before the 16th of March update. I don't think the sentence is entirely clear. I don't recall to what extent I would have had any contribution to that, but it's...
But you'd agree could seem slightly odd in this paragraph?
Yes.
If we can skip down to the sixth paragraph, please, bottom of this page. SAGE considered that measures relating to individual isolation will likely need to be enacted within the next 10 to 14 days to be fully effective, and those concerning household quarantining and social distancing of the elderly and vulnerable 2 to 3 weeks after this. However, the triggers for individual and household isolation could be met earlier, depending on the progress of the outbreak in the UK. Then if we can go over the page, please, to paragraph 9. Modelling suggests that the stringent interventions introduced in Wuhan from the 23rd of January may have reduced the reproduction number to below 1. However, there are differing views across the scientific community about whether other factors were involved in this. Just again, pausing there. What was your view about the efficacy of the measures that had been implemented in Wuhan?
So I think the measures in Wuhan and to an extent in northern Italy showed that it was possible to enact extreme social distancing to drive the reproductive number below 1 and actually suppress the wave. So I think it was empirically possible. The debate that I can recall was around the modelling and scenario planning as to what might be possible within the UK. And as I say, the thinking moved on from the flattening the curve to realising that actually it was not only possible to enact a lockdown, but actually it was necessary to avoid terrible loss of life and an impact on wider society. My impression of this document is it's maybe a few days behind some of that SAGE thinking, but I couldn't give you a day-by-day account of how those things went on.
Just have a look at a couple more paragraphs, if we may, in this document. Paragraph 10 next, please. Hong Kong and Singapore are undertaking extensive contact tracing as well as a raft of social distancing measures such as school closures, self-isolation, but not to the same level of stringency as seen in Wuhan. There's also anecdotal evidence of extensive self-isolation by the general population. The roughly linear increase in the number of cases in Hong Kong and Singapore suggests that this approach has held the reproduction number around 1. And then if we can please go over the page 3, and look at the second bullet point. Home and work-based distancing interventions have a greater individual impact when combined with self-isolation, household quarantine and social distancing of vulnerable groups and over 70s is predicted to lead to a 37% reduction in infection-related deaths. And then finally, please, paragraph 13 at the bottom of this page. A combination of these measures is expected to have a greater impact. Implementing a subset of measures would be ideal. Whilst this would have a more moderate impact, it would be much less likely to result in a second wave. In comparison, combining stringent social distancing measures, school closures and quarantining cases as a long-term policy may have a similar impact to that in Hong Kong, seen in Hong Kong or Singapore, but this could result in a large second epidemic wave once the measures were lifted. It's just, again, pausing there. It's right, isn't it, that Hong Kong and Singapore had experienced their own coronavirus pandemic in the last 20 years, so they had experience of multiple waves. Yes?
The SARS-CoV-1, I suppose it was a pandemic, but not in the same sense as, say, the 2009 pandemic, but they had experience of having to step up contact tracing and those sorts of interventions rapidly.
And had they not modelled the impacts of second and third waves as well?
I don't know what modelling they'd done at the time.
If going back to this document we've just been looking at, over the page 4, para 14, please. Timing of interventions would be critical. And then para 16, please. These interventions assume compliance levels of 50% or more over long periods of time. This may be unachievable in the UK population, and uptake of these measures is likely to vary across groups, possibly leading to variation in outbreak intensities across different communities. Can you help us? Where did that assumption come from, namely that a compliance level of 50% may be unachievable in the UK population?
I don't know where that would have come from. I'd say the arguments you presented here in this paper are sort of mixture of the pre-Riley paper about flattening the curve. There's the point about not putting in too many interventions, otherwise you'll get a second wave. But then the one above that you've presented shows about the ICU surveillance triggers, which was actually part of the mechanism for the repeated lockdowns that Riley was advocating, and then Ferguson's paper after that.
I mean, as a summary, by the 11th of March 2020, would it be fair to say that the following things? The timing of the MPI would be critical, as is stated in this paper. You'd agree?
Yes.
Earlier intervention led to quicker results. I'm afraid if you nod, we can't pick up your answer. Thank you. A combination of stringent MPIs, so home and work-based distancing interventions, self-isolation, household quarantine, social distancing of vulnerable groups, was likely to result in a 37% reduction in deaths.
Again, that came from the pre-Riley assumptions. I think that was not sufficient actually to suppress the epidemic. So that isn't suppression, that's a flattening the curve statistic in my recollection.
I understand. Lockdown in Wuhan was effective.
Yes.
Stringent MPIs in Hong Kong and Singapore also were effective.
Yes.
The ideal outcome would have been to flatten the curve and push the epidemic into the summer months.
I'm not sure. What are you asking, whether I think that now or whether that's an implication of the paper?
Whether at the time that would have been something that could have been safely assumed or thought.
I'm sorry, I can't really answer that.
Bearing this in mind and what we can see from this paper, why was lockdown not recommended by TAC at this point? So this is the 11th of March 2020.
So again, this is on my recollection, but I have gone back and read some of the papers and done some further thinking, so it is with the benefit of that. My recollection is, as I've said before, that the overall strategy that we were following was a UK strategy, that the chief medical officers had made an agreement that they were going to attempt to do the same thing at the same time, except where there were specific reasons for a different response because of differences in the NHS structure or whatever. So we were following a UK response. My recollection, and TAG would have reflected the discussion and the thinking within SAGE. My recollection was that the 13th of March SAGE meeting, there was a consensus that lockdown was necessary. There may be needed repeated lockdowns, etc., but actually that there needed to be extreme social distancing to suppress the epidemic and prevent really severe impacts on the population. And my recollection that after the previous papers about flattening the curve, that certainly by that 13th of March meeting, that there was a consensus within SAGE, albeit although I wasn't a member, so you maybe better ask people within SAGE, but actually that was what they were recommending at that time, and I would have thought that TAG and the Chief Scientific Advisor would have echoed those views, because that's the way that we were operating.
Now, we'll come on to that 13th of March meeting in a moment. Just, though, hearing what you've said, that effectively it would have been impossible to have locked down without UK government cooperation. Is that fair?
I mean, I can't say exactly how it would have gone, but I don't think it would have been feasible.
Do you not still think TAC should have at least considered locking down and advised the Welsh Government on locking down, leaving aside the practicalities or the relationship with the UK Government or what had been agreed at CMO level?
I suppose we could have considered doing that as a group, but recalling that the change in the thinking within the SAGE and modelling groups that we were relying on was only happening around this time.
Could we please have INQ 0002714443 displayed? Thank you. This is TAC's briefing on behavioural social interventions. We understand this to be dated 11th of March. If we have a look at point 4, please. The objectives of these interventions could be contain the outbreak so that it does not become an epidemic. Note, this is likely to be unachievable. Was considering the possibility then of containment completely unrealistic by this date, namely the 11th of March?
Yes, I think that's right.
And looking then at the next paragraph, paragraph 5, please. Any intervention would need to be government policy for a significant duration, 2 to 3 months, in order to see the benefit, as removing and or relaxing the intervention too early could result in a new outbreak and potentially extend transmission of the virus into winter 2020. Am I right in thinking that what this is saying is go too early and the peak of infections might simply be displaced to a worse time of year?
So the first part of the sentence is correct, that any serious intervention would need to be done for significant duration. It's also true that relaxing it could result in a new outbreak. Reading it now, it looks like a mixture of the two forms of thought at the time. But essentially, for a lockdown to work, you have to implement it for a sufficient amount of time so that you've suppressed the virus, and then you can then be sure that the levels are low once you've finished. What then happened after that is something that modelling might predict, but you don't really know at the time.
I understand. But does...
Mr. Paul, just before you go on,
Yes.
I'm really sorry. You said, am I right in thinking, your question was, am I right in thinking that what this is saying is go too early and the peak of infections might simply be displaced to a worse time of year? That's not how I read it. I read it, because any intervention has to be 2 to 3 months long, then you don't want to go too late, because otherwise you risk going into the winter months. That's how I read it. So I read it the opposite way from you.
Well, my lady, perhaps we can put that to Dr. Williams.
Which is the correct reading.
I have to confess I'm slightly confused by this paragraph, because it seems to be a mixture of flattening the curve and suppression, which was then moved on to. The problem with the was thought at the time was that suppression would work. So you put in interventions for 2 to 3 months, you would stop the epidemic for that time, but then after a while you would get a second infection, and then you would either have to lock down again or you would get a further wave. My also recollection is from the Riley paper and the others that they predicted that it would come back every 2 to 3 months, actually even more frequently than that, which wasn't actually the case in summer of 2020. So it took a longer time for the second wave to come around than they predicted.
Is it right that this is predicated on the fact of there being sort of effectively only one lockdown? It doesn't contemplate, does it, 2 or 3 successive lockdowns at specific intervals?
So, as I said, the Wiley paper from the 9th was starting to contemplate the idea of repeated lockdowns, or at least first lockdowns. I can't remember when the second paper came out, but actually did model repeated lockdowns. But this was around the time that thinking was changing. So that might be the reason that this document is maybe a mixture of those views, and was still reflecting the ideas of kind of flattening the peak, and also being concerned about not suppressing the peak, because then you would get another peak, but it would come in winter when we would have the flu and other things at the time. I think the idea of lockdowns was quite far from practice in people's minds, and the idea of repeated lockdowns was even further away. So maybe that's why the thinking was along those lines.
If we can please have a look at, I think it's page 6 of the document we've got in front of us. We can see there some of the modelling that was done. And I want to look, it's not, certainly if you're colourblind, you won't be able to follow this, but I think you can just about see it's I'm looking at the grey, thank you, the grey dashed line.
Yep.
Is it right that represents, looking at the key, school closures, case isolation, household quarantine and social distancing of the entire population? So yes. It is the scenario most like what we saw enacted over a week later, which we're coming onto in a moment. Yes?
That's right, yes. So the SD is the additional social isolation, yes. And it shows it's suppressed the first peak completely, but then you get a much larger peak. It predicts actually into the summer.
And is that because, as you've just described, a sort of reduction in case rates by mid-May and then suddenly a number of cases sharply increasing? Is that because the model assumed that the set of restrictions would be lifted effectively all at once, and then case numbers would increase in the population at that point?
I can't remember the exact assumptions, but there would have been something relatively simple like that yes, we assume that restrictions are in place for X amount of time and then either gradually or immediately removed.
Can you recall, did anyone ask about, going back to my previous question, about multiple lockdowns or the staggered releasing of restrictions, or were those questions that were not being asked at this time?
I think the staggered release of restrictions, I can't recall exactly what the modellers did, but they would have probably tried to put simple on-off things within the models at this stage. Certainly, I think they were modelled later with staggered restrictions. And the idea of repeated lockdowns was, I think, the paper after this, when, again, I can't recall exactly, but I'm sure there were papers from Riley and papers from Ferguson, probably Edmund's group as well, showing what would happen if you locked down for a period and then you used good surveillance to watch until there were a certain number of cases emerging, I think, in intensive care, and then you locked down again based on that number. So those are the models they were starting to run a little bit after this paper.
Now, on the 12th of March, the UK government announced that from the following day, 13th of March, those with coronavirus symptoms, either a new continuous cough, high temperature, should stay at home for at least 7 days, and all those over 70 and those with serious medical conditions also advised against going on cruises. Now, obviously, that announcement fell short of a mandated lockdown. What warning were you given, Public Health Wales given, or yourself, or TAC given, ahead of that announcement by the UK government?
beg your pardon, is that the 13th of March?
This is the announcement on the 12th of March with the restrictions coming into effect the following day. What warning, if any, were you given about that announcement?
I don't recall being given any warning.
Were you surprised that an announcement like that would be made without your input and without any prior warning?
I can't recall if I was surprised or not. I think I was surprised that it wasn't a more complete lockdown.
And at this point, so now 12th of March, was the scientific consensus in Wales in favour of restrictions being imposed only and no further, or in favour of an immediate lockdown, to your recollection?
My recollection, as far as it goes, was that we'd thought that given all of the preceding papers, that by that 12th of March, that there would be a UK-wide mandated full lockdown, given the sorts of warnings that were given in the Riley and the Ferguson papers.
Given that that was your view, and I think I'm right in saying a sort of a scientific consensus view by the 12th of March, and you were surprised that the 12th of March announcement hadn't gone further, did you speak to anyone about this? What did you do?
I can't recall exactly my verbal or written communications at the time. As I say, my understanding at the time was that we were working as a Four Nations, as a UK-wide response, and it would have been very difficult to lock down in Wales and not lock down in England. And certainly we found subsequently, there's a lot of movement across the border. It only really works properly if there's a UK-wide intervention.
You said earlier that you worked quite closely with Dr. Orford, Chief Scientific Advisor of Health in Wales. I mean, at this stage, did you raise your concerns with Dr. Orford? Can you recall?
I don't recall whether I raised them in a written format. I think it's probable that if we'd had any telephone meetings or similar at the time, that I would have expressed surprise that was the response.
Now, I think it would be a fair summary to say that between this date, 12th of March, and the 20th of March, those on TAC were becoming increasingly concerned about the approach being taken in Wales to the pandemic. If I can just anchor that in perhaps a point in time, on the 15th of March, TAC authored a paper for the SAGE meeting that was to take place the following day. I don't want that paper pulled up, please. It's TAC's recommendations for the Welsh Government. And the summary, executive summary, reads, TAC Group recommends that unless the requisite resources for the NHS to prevent it becoming overwhelmed are identified in the next 7 days with a clearly defined plan to implement them in a timely manner, a policy of more stringent intervention should be considered for Wales. Why was that your advice, or TAC's advice at that time?
I think that was to do with the NHS capacity, that it would need to be greatly augmented if we were going to have a big wave.
So was there a concern that unless more stringent interventions were immediately put in place, then the NHS in Wales risked being overwhelmed?
Yes, that was a concern at the time.
Do you think, looking back, that advice was went far enough?
I suppose even even at the time, I did wonder whether we, including myself, could have done more to argue for an earlier lockdown, given that the UK-wide lockdown didn't happen when we thought it might have done. The only other thing I would say is that we were ever so slightly behind the epidemiology in England. So actually the case numbers were maybe a week or something behind the numbers in England. And there was rationales for timings of lockdowns. But yes, I have wondered about whether I should have argued harder for something to be done. But I'm not sure it would have made an awful lot of difference.
I mean, doesn't being a week behind, epidemiologically a week behind, doesn't that in fact give Wales sort of effectively a head start, and it would allow Wales to get ahead of the curve?
you need to time the lockdown so that you don't. I think I recall John Edmonds' testimony is you don't do lockdown when there's just only one case, because that's clearly too early. But then when there are too many cases, that's too late. So somewhere between one and the other, and the papers were arguing for earlier lockdowns. I don't know exactly how that timing would have worked for Wales, but as I say, at the time, it just wasn't aware that it was an option.
Now, 5 days later, on the 20th of March, TAC was asked to commission a paper on lockdown measures, and then a TAC advisory paper was published on the 23rd of March, which again advised on, it was entitled Lockdown and Release Strategy. So that appears to be the first formal interrogation by TAC into national lockdowns. Is that right? Is that your recollection?
I would have thought, given that there was the feedback between SAGE meetings and TAC, that some of the other papers and repeated lockdown papers would have been discussed within TAC, but maybe that's the first time it was formally put down on paper. Was
TAG and TAC consulted on the ultimate decision to lock down on the 23rd of March?
I don't recall the discussions being of that variety, but yeah, I don't recall. You'd have to ask them about the minutes.
In your view, should Wales have locked down earlier in March 2020?
So my view is that the UK should have locked down earlier, and ideally, on the 12th of March, or possibly even earlier than that, partly because of what the modelling was saying in terms of the timing of the lockdown in relation to the impact, and also partly because we had evidence that it would work from Wuhan and Italy.
What would the impact of an earlier lockdown have been on later waves?
It's very difficult to answer that. I think it would have reduced the impact on the first wave in terms of hospitalisations and deaths. However, it might have been that there would have been a rebound effect over the second wave, and we did see that to an extent that we were actually slightly less impacted relative to population in the first wave, but then slightly more in the second wave. This is from some of my subsequent reading of the figures from the time. So there is an extent to which what you don't get in one wave you do get later on, unless it's a very well enacted and early suppression the second time.
Now, Dr. Williams, just want to change topic, if I may, and ask you some questions about asymptomatic transmission of COVID-19. And again, I want to try and take this chronologically, if I can. What did you know about asymptomatic transmission in early January 2020?
So, again, I'm not sure it would have been something that I thought about greatly, but I can say that professionally I would have assumed that there was likely to be an asymptomatic infection, and this just from my experience of other respiratory viruses. I know SARS-CoV-1 didn't generally have asymptomatic infections, but SARS-CoV-2 does, and influenza certainly does. Whether those asymptomatic infections were detectable by testing and whether they were transmissible is a separate question.
I think on the 29th of January, you and your colleagues at Public Health Wales received an email from Public Health England attaching a paper on asymptomatic transmission. Again, I'm not going to ask for it to be displayed, but that paper, if you recall, it outlined early credible evidence of asymptomatic transmission from an individual in Germany who appeared to have been infected through her asymptomatic parents. Do you recall this paper that I'm talking about? Yes. And the paper concluded that the currently available data is not adequate to provide evidence for major asymptomatic subclinical transmission of 2019 nCoV, but that there was evidence of small-scale anecdotal asymptomatic transmission. Was it your view as an epidemiologist that it is better to keep an open mind about transmission possibilities?
I think in general it is. What you don't know is to what extent they play a role in terms of the transmission of the infection. So something may be possible but not a major factor, or it may be possible and a major factor, and it's hard to tell particularly early in the phases.
Was it your view that the best approach would be to assume that asymptomatic transmission was taking place?
I can't really answer that. You have to think about also the implications of assuming asymptomatic transmission, which would, given the case definition at the time was travel from China or Wuhan with symptoms, you then quite quickly shift that to anyone who's travelled from China, which I don't think would have been very feasible in terms of follow-up, and probably you would have then had to think about, what would the next step be. So maybe that's the light in which it was considered. But yes, it's always worth considering on a precautionary basis what might be transmission routes.
Moving forward chronologically then, so that was a paper that was shared with you on the 29th of January. On the 17th of February 2020, the Diamond Princess asymptomatic cases were discussed in a SAGE meeting. Do you recall discussing the evidence of asymptomatic cases on the Diamond Princess in TAC?
I don't recall those discussions in TAC. I'm sure there would have been, we got reports on the Diamond Princess through the PHE meeting, so I'm sure there would have been some, at least information on that, but I don't recall discussions in TAC.
If we can please have INQ 000119469 on screen. This is a minutes of a nerve tag meeting of the 21st of February 2020. And if we could please have page 6, paragraph 3.4. Thank you. NF noted that there were a few modelling groups estimating a higher infection rate when comparing case populations in Singapore, South Korea and Japan. This suggests that at least a third have been missed. JE commented on this after the meeting, taking into account the issue of asymptomatic cases, where the evidence suggests that 40% of virologically confirmed cases are asymptomatic. Do you recall being informed of this?
I don't recall that particular. I wasn't on Nerve Tag or didn't receive the minutes from Nerve Tag, but I'm sure the figure of from what was happening in Diamond Princess was probably reported elsewhere.
And so by late February, were you and your colleagues aware that asymptomatic transmission was taking place and the extent of asymptomatic transmission could be as great as 40%?
So I can't recall, but I'm sure it would have been part of the thinking.
And did TAG or TAC formally advise the Welsh Government at this point in late February about the potentially very high rates of asymptomatic transmission?
Again, I can't. TAG, as I mentioned earlier in my statement, TAG was one of the things that I was involved in. My role was mainly to give epidemiological updates, and my main role was within Public Health Wales, so I don't recall absolutely all the discussions in TAG at the time, unfortunately.
Dr. Williams, I'm going to change topic again and talk to you next about first discharge of patients from hospitals, care homes, and also then testing of our care home staff. Now, as I'm sure you may be aware, there is a later module of this inquiry that is going to be looking at the care sector. But within this module, we are looking at high-level core Welsh Government decisions that might have impacted on the care sector. Were you involved in providing any advice about discharging patients from hospitals to care homes in February to April 2020?
February to April. Not that I can recall between February and end of March, no.
Is it right that you have subsequently worked with colleagues to address the question of transmission to care homes from these discharges, so namely discharges from hospitals to care homes?
Yes.
And that work, am I right in saying, has largely confirmed that transmission to care home residents was driven by their exposure to the community through staff rather than from hospital discharges? Is that right?
That's the broad conclusion. I just want to caveat that by saying that, of course, it's possible for care home residents from discharges, particularly earlier in the pandemic, to have then gone on to cause transmission within those homes. I'm not arguing at any point that wasn't a possibility. We just felt that there was a bigger risk and an ongoing risk from the community to staff to the care home, and that was something that was potentially amenable to change, and that's why we did this work.
So from the point of view of care home outbreaks, the testing regime of care home staff and residents was important in terms of saving lives, possibly more important than the policies around discharge from hospitals. Is that fair?
I think it's the whole package of what you would do around care homes, how you would support the staff, how you would support the work within the infection control and things like that within the care home, rather than simply the testing policy versus within staff versus the testing policy on discharges.
Can we please have INQ 000228309 displayed? Thank you. Now, this is an email chain. It covers the 31st of March through to the 1st of April. It's between Dr. Thomas Connor, yourself, Dr. Orford, and other members of TAC. And just by way of context, Dr. Connor has circulated a paper on nosocomial outbreaks. And given the spread of outbreaks observed in a hospital in late March 2020, the issue was raised as to how effectively you could test healthcare workers to ensure that positive cases of COVID were caught. So just with that context, if we can go please to page 2 of this email chain, I'm grateful. At the bottom email, it's an email from Dr. Connor, yes, on the 31st of March, 2241. And then over the page, it goes to page 3, paragraph 4. I'm grateful, yes. Just thinking in terms of timescales, the potential for routine testing to have picked this up is very contingent on how that testing regimen is designed. In this case, we have a cluster of 50 to 70 cases who all flagged positive within around 7 days of the suspected index case. That, to me, suggests how one implemented something like weekly testing would be critical in catching something like this early. I would think that if a portion of staff tested every day, then detection that there is a problem on a ward might be possible. But say testing everyone once a week could conceivably have missed basically all the transmission here. So to me, the message is to design routine testing well, taking into account the observed timescales in AB, and understanding that such testing has to be rapid to be useful. AB being the hospital that I referred to when giving context to this email chain. Then if we can please go page 2 to the top email. This is your reply on the 1st of April. And I'm looking at the second paragraph, 5 lines down, starting on regular testing. On regular testing, I was thinking of a different scenario whereby healthcare workers could be infected at home rather than on the ward, agree that only daily testing would be secured, but weekly testing would help to give routine reassurance and also set up a rhythm and acceptance of testing and self-consideration of symptoms. Of course, you can be unlucky with this too and miss a whole week, but I think it could work, and I think have seen that it's been used elsewhere. We'll check. Now, you say there's self-consideration of symptoms. Did you consider the role of asymptomatic transmission when considering this advice, Dr. Williams?
I believe so, yes. So this was the outbreak that Tom refers to was one in an Island Bevan that actually my team had investigated initially. We found this number of cases, and then Tom had added on to that with a genomic analysis to try and work out what the chains of transmission were. And this was then leading into a discussion about how healthcare worker testing might help mitigate the transmission in the hospitals, both between staff and patients and staff, but also to staff at home. So we started to discuss the timing of that and how you would optimise it. You also have to remember about the performance of tests and things like that.
Would it have been more prudent to advocate for testing more frequently than once every 7 days, as Dr. Connor has done?
I think we were both discussing whether weekly testing would work and how many it would miss and what pattern you would use, rather than that he was arguing for daily testing and I was arguing for weekly. Because I think it was in the understanding of asymptomatic cases, and the fact that healthcare workers do tend to carry on working even if they've got mild symptoms or sometimes with severe symptoms. And actually, I think what I was trying to say here was that giving people a test and then it turned out to be positive maybe before symptoms would at least give them the rationale that they would not then go to work whilst infectious. So there's quite a lot of things going on here.
Was it your view that there needed to be some routine testing then of healthcare workers at least once every 7 days?
That's my recollection. These email chains will allow me time to argue for that.
On the same day, about 2 hours later, you emailed Dr. Orford. If we can please have IMQ 000224062 on the screen, thank you. You emailed Dr. Orford. This was a CDC study about the high proportion of healthcare workers testing positive for COVID-19 and care homes who were asymptomatic. As we see there, email at the top of this page, we'll try to discuss this offline with Robin. Whilst it is true that the NPV of the test is low, it is also true that potentially a high proportion of those testing positive and therefore likely shedding are asymptomatic, see below in context of care homes. It is also true that HCW will continue to work whilst symptomatic despite guidance. And then email from Dr. Orford, slightly above that one, please, says it would be good to discuss it would be good to understand, if there is more data out there on higher intensity testing of HCWs. Also, it is a risk-based approach to mitigate nosocomial outbreaks. Whilst it may have a low pickup, it might have a marginal gain and also a psychological barrier for HCWs. What did you understand by Dr. Orford's response? What did you understand that to mean?
I think I was arguing for routine testing of healthcare workers who could pick up both pre-symptomatic, mild symptom and asymptomatic infections. And Rob is just asking if there's more evidence on this. I don't know about the marginal gain. The negative predictive value point is that when there's little infection around, there's lots of infection around, that negative tests might not necessarily mean that person's negative. So it might provide false reassurance. But I don't know exactly what he means in that second sentence.
Perhaps to summarise then what was known, what you knew by the 1st of April. You knew it was essential to routinely test healthcare workers to avoid transmission to patients, yes?
I wouldn't say I knew it was essential, but I was suggesting that might be a means of preventing transmission, yes.
Understand. Symptom-based screening alone would fail to identify COVID-19 cases.
That's what I thought, yes.
So routine screening of everyone, so symptomatic and asymptomatic, was really the only effective way to avoid transmission of COVID-19 from staff bringing community infections into a care home. Is that right?
I think that was part of my thinking. I mean, it's a very complex area, but yes, to pick up those asymptomatic infections, you needed a test.
And if asymptomatic transmission accounted for up to 40% of COVID cases, testing symptomatic individuals only could miss up to 40% of outbreaks on any one day. Is that?
Yes.
And if some healthcare workers would continue to work whilst symptomatic, even more infections would obviously be missed. Is that right?
If they were symptomatic, they wouldn't necessarily be missed. Someone would know about them. But, yeah.
I'm grateful. Well, lady, I'm not going to quite finish this topic, so that might be an appropriate
Certainly,
point for a break.
11:30. Mr. Poole.
Dr. Williams, we were just talking about the position as of 1st of April. Just want to move forward a few weeks to the 17th of April, and there was a Public Health Wales Strategic Coordinating Support Group meeting on that date. You provided an update on the situation in care homes. You said 300 care homes are reporting COVID-19 activity, roughly 25% of care homes in Wales. And then your colleague from Public Health Wales provided some further information and said, to date, 322 of 1,302 registered care homes in Wales have reported COVID-19 activity. A total of 153 cases have been confirmed. Since 9th of April, Public Health Wales have been offering testing of symptomatic and asymptomatic staff. There is a 62% positivity rate of staff tested. Was this a policy that had been rolled out across all care homes in Wales, to your knowledge, with mandatory testing, or was it being provided only to care homes as and when outbreaks emerged?
My recollection, it was for outbreaks.
A 62% positivity rate for staff tested must have been very concerning.
That is a high rate, yes.
And of those tested, more care home staff than not were positive for COVID, 62%.
It's over 50%, yeah.
Given the number of outbreaks in care homes across Wales at that time, coupled with what we've just discussed about your knowledge of asymptomatic spread, did you think that rollout of mandatory testing of all staff and residents should take place at that time?
I don't recall what my views were at the time. I think there was a meeting the following day that moved things on a little bit, but no, I don't recall.
Taking a look at what was happening in England, on the 14th of April, the UK Chief Medical Officer's advice was that testing within care home settings was a priority, following concern highlighted by a study of 29 care homes by Public Health England. And then on the 28th of April in England, the Department of Health announced extending testing to all residents in care homes, irrespective of symptoms. There was a ministerial advice on the scaling up of testing in care homes that was provided to Vaughan Gethin on the 30th of April. It's INQ 000116607, which is up on the display. Thank you. Did you contribute to that ministerial advice?
I don't recall that I did, no.
Perhaps we can just have a look then at page 4, paragraph 16. Under the impact of asymptomatic care home residents, reads... first bullet point, a pilot study recently undertaken by PHE in 6 care homes in London reported an outbreak tested all residents and staff groups. Preliminary results from 1 care home with over 100 residents investigated at an early stage of the outbreak in the home. 75% of residents were positive for Covid-19, but only 25% were symptomatic. 50% of staff were positive, but only 29% of these were symptomatic. And if we can please go to page 5, paragraph 21. Paragraph 21, thank you. Discussions with colleagues in Welsh Government and PHW indicate that testing of asymptomatic or reportedly so care workers would help to prevent introductions into care homes and also provide an estimate of community incidence of COVID. And then please, paragraph 23, bottom of that page, thank you. Under the options, there are limited options. Do nothing is not an option. Expanding into asymptomatic individuals still lacks the evidence base to support this being the best use of testing capacity. So by this point, there was peer-reviewed evidence in favour of routine testing in care homes from that CDC study 1 month prior. Do you agree with the statement that there wasn't an evidence base to support mass testing that we see in this document?
I don't think that's correct in the framing the question. So the CDC paper found that there was asymptomatic infection, but it didn't necessarily advocate for routine testing of asymptomatic staff. I think a follow-up paper and an editorial in the New England Journal later in April, I think before this but after the previous ones, started to advocate for regular testing. However, there wasn't evidence, i.e. trial evidence showing that if you took X number of care homes and tested all of the staff and residents, and then you took some care homes and didn't, that actually this would improve outcomes. So I wouldn't say that there was strong evidence, but on a precautionary basis, I think I was advocating for some kind of routine testing of staff through my citing of the paper on the 1st of April and also some documents on the 18th.
I understand. And is it a fair interpretation that the reference here to the best use of testing capacity, that there were capacity issues with testing, and so the advice was perhaps to prioritise their use elsewhere, so in hospitals and for symptomatic key workers?
Having reviewed this document, which I don't recall seeing at the time, but having reviewed this document, it does seem to make mention of capacity. I think there's also a reference to 25,000 tests or something like that in relation to residents and capacity.
And just finally, on this topic, annexed to this ministerial advice is a document titled Summary of Discussion on Prioritising Tests for Care Homes, INQ 000116607. If that could be displayed, please. page 10. And this document proposed prioritising blanket testing of symptomatic and asymptomatic staff in certain care homes, those with an outbreak, COVID-free homes, struggling homes. And in this annex, it is noted, I think it's page 11, paragraph 2, if we can see that, please. FA, this is Dr. Atherton, indicated that it would have been helpful to have this information earlier, as it had caused enormous issues in Wales. Proved very difficult situation as the media had picked this up as a very significant divergent of policy. There was a 4 nations group on testing, but Wales did not seem to be fully plugged in. In your view, insofar as you can answer, as you weren't cited on this paper at the time, was Dr. Atherton fair when he said that Wales was not fully plugged in on this issue?
I wasn't a member of the 4 nations testing group, so I can't really comment on that.
Dr. Williams, changing topic and briefly touching on the question of face masks, face coverings. That was obviously one area where there was a difference of opinion between the 4 nations. I'd just like to ask you a few questions about this. On the 11th of May, the UK government advised the public to consider wearing face masks in enclosed public spaces. And in terms of what we know happened in England, on the 5th of June, face coverings were required in hospital settings. On the 15th of June, they were required on public transport. And then the 24th of June, they were mandatory in shops and supermarkets. On the other hand, face masks only became mandatory on public transport in Wales on the 27th of July and in shops and other public spaces on the 14th of September. There's a tag advice dated the 8th of June 2020. I don't need to go to it, but it did not explicitly advise that masks be mandated in public. And on that same date, Dr. Atherton advised the First Minister on this topic, and he said, "I remain of the view that the evidence of benefits does not justify a mandatory or legislative process, and I still see dangers in taking such an approach in Wales." Do you agree with that advice?
I can't recall at the time, but not necessarily, no. I think I put in my witness statement that I thought that it might be worth a try, the masks, even in the absence of good evidence, knowing that it's very hard to get definitive evidence for an intervention such as face coverings.
And as you say, I think you say in your witness statement on face coverings, I can recall arguing verbally in TAG in favour of their use, even in the absence of evidence. That's right.
That's correct, yes.
Moving then to another topic, again, fairly briefly, just super spreader events. The Six Nations men's rugby match between Wales and Scotland, as we've heard earlier, was due to take place on the Saturday, the 14th of March, 2020. Welsh ministers declined to intervene to stop that match, and the Welsh Rugby Union ultimately took the decision to postpone the match lunchtime on the day before, but by which time 20,000 Scotland fans had already arrived in Cardiff. There were also 2 Stereophonics concerts on the 14th and the 15th of March held in Cardiff. Now, your views were expressed in a briefing to TAC around the 10th of March was that the modelling evidence did not show a major impact of mass events on overall transmission. Do you stand by that advice?
I think that's certainly what the modelling was showing at the time. I still think that mass events don't generally have a huge impact on transmission because there's a lot of transmission going on elsewhere. But of course, it doesn't mean to say, as with my previous answer, that transmission can't or doesn't happen at mass events.
Now, one of the reasons the Wales and Scotland match was not cancelled was, as I understand it, due to a concern about socialising displacement, so people going to more pubs and restaurants if the match was cancelled. Now, in light of what we know about voluntary reductions in contacts and socialising in mid-March, do you think those concerns were well-founded?
I think the concern that transmission could happen better in closed environments like pubs and restaurants, it was correct.
Are you able to assist at all with what might have happened to COVID-19 community caseload progression in Wales in March 2020 had those events not proceeded?
I couldn't say how it would have changed things. I think there's evidence from some some evidence of lower effects from mass events and some evidence, I think there was one in Scotland where there was quite a large impact on transmission, but you have to look at the circumstances in the particular events.
There's also the impact on public behaviour, isn't there?
You could see it as part of a wider
You allow a mass
consensus on
event to go
public
ahead,
behaviour,
it gives
yes.
the public the message everything's fine.
I agree, and yes, that should be consideration.
Dr. Williams, finally, and again, a slightly different topic about school closures, if I may. You briefly mentioned school closures in your evidence, and in your witness statement, paragraph 118, you say, regarding schools, I thought it was important to set the risks here in context, given the relatively low severity and burden in children and the negative effects of school closures. What, in your view, were the risks to children in schools?
I think the risk of infection, severe outcomes in children was low, and that was reasonably well recognised at the time. I have children of my own, and I know that the effect of them not going to school might have been damaging to their education and other parts of their social development. And I also knew that there were a lot of concerns about transmission in schools, both driving the epidemic and also within the workforce.
In the passage I think we've got on the screen in paragraph 108 of your statement, what do you mean by setting the risk in context?
I think in the context of what the risk was in the rest of the population, that I think I was concerned that maybe schools were seen as a sort of magic bullet to, you close the schools, you can really nip some of the transmission in the bud, and that's partly based on experience with flu, where we know children play a large role in transmission of influenza and with other infectious diseases. But I thought it ought to be balanced with the knowledge that the outcomes were generally pretty good in children.
And how were the risks assessed for school children in Wales?
As I say, we set up a report to try and report on the numbers of cases in both school children and also in staff, to try and say what they were and also compare them to the sort of incidents and the indicators in the local authority population at the time, just to make that comparison.
And again, looking at this paragraph of your witness statement, what do you mean by the negative effects of school closures?
So, in addition to the effects on the students themselves, I think there was also recognition that closing schools has a big impact on parents. Particularly, there was concern about healthcare worker parents and other sort of staff that then wouldn't be able to go to work because the school was closed. So I think that was part of the wider considerations. But yeah.
Dr. Williams, there are all the questions I've got for you. I think there are some Rule 10 questions for you.
Right, I think, Ms. Heaven, you're asking some questions?
Yes. Good morning, Dr. Williams. I represent the Covid-19 Brief Families for Justice Cymru. Just two topics, please. I want to come back very briefly to face coverings and then the autumn fire break. So, my lady, for your reference, I'm swapping round the two questions on which I've been granted permission. CTI has just covered with you what you say in your statement, but can I just read it back to you and ask some targeted questions? So it's 119 of your statement, don't worry. You say, on face coverings, I can recall arguing verbally in TAG in favour of their use, even in the absence of evidence. As I knew, there was evidence from SARS-CoV-1 that surgical face coverings had a protective effect in hospitals, and also that they were likely empirically to be effective, and that a measure with low effectiveness deployed very widely can have significant effect. So, two things firstly, can I just check here? You're obviously talking about advocating for surgical face coverings. Are we talking here about fluid repellent surgical masks, to give it its technical term?
I think so, yes. I mean, I just meant face coverings in general.
Okay, that's helpful, because my next question is going to be, it seems that you're also talking about advocating for face coverings in the community in TAG.
That's my recollection.
Okay. Now, you're saying in your witness here, your statement, you're arguing verbally, and that's obviously your word, in favour of face coverings. And it would seem to be that you're suggesting that as an infectious disease epidemiologist, you were facing some opposition in TAG to your views. So is this correct? Were you facing some opposition, and if so, from whom?
I can recall there were arguments about other negative impacts of using face coverings in different groups. I can't recall who in particular might have made them. Also, on the case of things like face coverings and you mentioned surgical face masks, that tends to be the purview of people with infection prevention control expertise and microbiologists, and that's not generally my area of expertise.
Well, can I just prompt you, were you facing some pushback from Frank Atherton, CMO, on face coverings? Because we obviously know from the evidence that he was not in favour of them in the community for quite some time.
Frank Atherton wasn't a regular attender at TAG meetings, so I don't think that it would have been him.
Okay. Second question then, please, is just generally, you have given some views, but I want to be absolutely clear on your view on the approach taken by the Welsh Government to face coverings. CTI has taken you through the dates. We know that on every measure the Welsh Government diverged and was later than all the other 4 nations in their approach to recommending and mandating masks. Robert Hoyle, who was from a TAG subgroup, told the inquiry yesterday the Welsh Government should have mandated masks much earlier. To be absolutely clear, do you agree with his view?
I think that would have been a reasonable approach.
You've also just been asked by CTI about the approach Frank Atherton took in May, and I know you didn't see the document. We know that Frank Atherton was giving advice in May that face coverings were essentially a matter of personal choice, directly contrary to the evidence we heard in Module 2 was being given by Chris Whitty to the UK Government. Do you have a view on the Welsh Government's approach in May 2020 to face coverings?
I don't really have a view, no, not beyond what we've just discussed.
Okay. Next topic then, fire break. And again, I'm going to read to you, if I may. It's paragraph 117 of your witness statement. You say, I was an advocate for lockdowns when rates were rising, given my experience from March 2020. In autumn 2020, surveillance data was used to guide local and regional levels of restriction, and I was involved in explaining these data to groups advising on these. On the fire break, I recall verbally advocating for a long enough period to be significant, but I was aware that there were constraints in feasibility and also that an intervention not mirrored across the border would have more limited effects. So the first topic is on the timing of the introduction. Were you advocating for the fire break to be introduced earlier, and if so, to whom? And if I can just ask the next one, because you can answer it together, please. Should the fire break have been implemented sooner? So did you want it at the time to be coming in sooner? And now thinking back, should it have come in sooner?
I don't recall that in particular. I know there's other evidence from Public Health Wales advice on the fire break intervention. All I can recall at the time is advocating for some kind of national restriction because the rates were rising, and also for a significant length of time because we knew it wouldn't have much effect if we did it for a short period of time.
It doesn't say in your witness statement when you were advocating. So when were you advocating for national restriction?
Again, I don't have records to. I don't have records to say exactly what I was saying at the time. I feel that a prolonged fire break at the time might have actually pushed the larger wave more towards when we had vaccinations, but I don't think that was really a feasible option at the time, unfortunately.
Okay, that was going to be my second question, is should the fire break have been longer? And I think you've sort of answered that, haven't you, by saying you thought it probably should, but that probably wasn't feasible to push the fire break longer into when the more vulnerable groups had been vaccinated.
Yeah, you'd have to ask Welsh Government colleagues the reasons for feasibility, but you can still see the fire break as a notch in the data, so it had some effect. What
about a 4-week fire break? Was that something that you think perhaps would have been sensible? So not right into the December period, but just 4 weeks?
I really can't say what the difference would have been. I would have probably thought that would just have given a bigger notch. In the event, we had quite a prolonged period of lockdown after the December restrictions that were actually a lot longer than any period that was advocated in the autumn. That's just a reflection with hindsight.
Yeah. OK, thank you very much. Thank you, my lady. Those are my questions.
Thank you, Ms Heaven. Ms Webster. Sorry, did I pronounce that correctly? Can't do it.
That's right, thank you. Good morning, Dr Williams. I represent John's Campaign and Care Rights UK. I'm going to ask a few short questions about your role regarding non-pharmaceutical interventions. I'll refer to them as MPIs. At paragraph 116 of your witness statement, you note that your role in relation to MPIs was mainly to provide information to assist with decision-making. Was it within your role to provide information not just about harm caused by COVID, but also to provide information about all relevant harms to health, in particular indirect harms resulting from MPIs?
So I do recognise that there are a number of indirect harms from MPIs, but I work in the infectious disease surveillance department. I felt it was my role to give the information about the epidemiology of infectious disease, and that others were better placed to give data and advice on other harms.
I would refer next to a document which I hope can be brought up, which is INQ 000 183846. While I just wait for that document to come up, this is a statement from Professor John Watkins, also a consultant epidemiologist, who worked, amongst other roles, for the policy modelling group feeding into TAG and the social care working group feeding into SAGE. Yes, this is the document, and within that, if we could go to page 16. And under the heading, wider non-COVID-19 related harms to MPIs, there's a paragraph under that heading, and about halfway down the paragraph, Professor Watkins says that he highlighted early on that people with mental health issues may be harmed by a lack of social contact. People with early stage cancer and CVD, cardiovascular disease, may not get the diagnosis and treatment they needed. Children's education and social development was being impacted, etc. Despite raising these issues, I saw no attempt to quantify or consider these when restrictions were being imposed. Were you also aware of concerns of this nature?
I don't recall what the discussions were in TAG, but I think the immediate problem was to avoid a huge health impact from a large wave of COVID-19, and I still don't think that could have been avoided in any other way than a lockdown, despite the negative aspects to it.
And in 2020, was there an attempt to quantify or collect data or even consider the more indirect harms resulting from MPIs?
I don't recall that from my own work, or it might be other people's evidence, but remember, my specialist is in infectious disease epidemiology.
And you may not be able to answer this given what you've just said, but my final question is, to what extent were the adverse impacts of MPIs on people in care or those needing care analysed? To what extent was data or expert input obtained for the benefit of core decision makers and in order to be weighed against the benefits?
I can't answer that, I'm afraid. I'm not part of that evidence.
Thank you.
Thanks.
Thank you very much. Thank you very much, Dr. Williams. Thank you for your help.
Thank you.
If I can... Oh, wait.
Mr. Poole, Mr. Whittaker, don't worry. The question wasn't asked, so we're moving on.
Exactly, my lady. Can I call Dr. Roland Salmon, please?
I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. You're welcome. Thank you. Good morning.
Hope we haven't kept you waiting too long.
No. Dr. Salmon, could you please start by giving us your full name?
Yes, I'm Roland Lawrence Salmon.
Dr. Salmon, thank you very much for attending today and giving your evidence. If I can just ask you to keep your voice up so that we can hear you, also so your evidence can be recorded. If I ask you anything that isn't clear, please do ask me to rephrase it. You have kindly given a witness statement to this inquiry, INQ 000224354. We can see that on the screen. We don't need to go to it, but at page 16, you've signed and dated this statement on the 14th of July last year. Are the contents of that statement true to the best of your knowledge and belief?
Yes, they are.
Dr. Salmon, in terms of your professional background and career, between 1990 and your retirement in 2013, is it right that you worked as a regional epidemiologist for the Communicable Disease Surveillance Centre Wales, and from 1998 you were its director?
Yes, that's correct.
You spent 8 years up to 2019 as a member of the Department of Health's Advisory Committee on Dangerous Pathogens, including 2 years as acting chair and 8 years as chair of its transmissible spongiform encephalopathy working group. Is that right?
Yes, that's correct. I was succeeded by one Chris Whitty.
The inquiry knows him well. From 2003 to 2013, you were a member of the Scientific Advisory Committee Conseil Scientifique of the French National Institute for Public Health Surveillance, and subsequently until 2016 a member of its management board. Is that right?
That's correct.
And I think you have been a senior crematorium medical referee for Cardiff Council Crematorium since 1999. Is that also right?
That's also correct.
In terms of your role in the Welsh Government's response to the pandemic, is it right you never sat on TAG or TAC or any of their subgroups?
I had no formal role at all.
And is it right you had no formal communication at any level with the Welsh Government or its advisory groups throughout the pandemic?
Yes, that's also correct.
Now, I plan to ask you some questions in a moment about the overall notion of population immunity and shielding. But first, if I may, I want to address some comments you've made concerning the preeminence of modelling and modellers in the pandemic and the figures that those modellers used. Now, in your witness statement, you have commented that in TAC, it was, your words, mathematical modellers that dominated the agenda. Now, you obviously confirmed you were not a member of TAG or TAC. The inquiry has heard evidence from a member of TAG and TAC a moment ago, Dr. Chris Williams, who was a consultant epidemiologist. The inquiry has also received written evidence from other members of TAG. So Jonathan Price, he's the chief economist. Dr. Catherine Moore is a microbiologist. Dr. Brennan Collins is the head of health economics. And later on this afternoon, we will hear from Professor Anne John, who's an expert in public health and psychiatry. So on the face of it, the membership of TAG appears broad. I just want to understand the basis for your comment in your statement that it was mathematical modellers that dominated the agenda.
Yes, certainly. I mean, you'll be the first to point out, Mr. Paul, that is, of course, hearsay, and I would be the first to concede that point and to recognise that there were, as I think I put in my statement, there are a number of other individuals with other skills particularly relevant to communicable disease. However, the outputs and the emphasis that was put on particularly the R number and on social distancing suggested to me that the particular discipline of mathematical modelling was rather more dominant. And I also drew on my own experience of being on these sorts of committees. And we had, of course, had interaction with mathematical modellers on the Advisory Committee on Dangerous Pathogens, on the committee in France. And one of the things that you will find with any group of scientists in the room is that there will be a number of opinions, or at least 2 or 3 opinions. They have to be synthesized in some way. And then, of course, along come the mathematical modelers with some very neat numerical constructions. And there's always a little bit of a tendency to heave a sigh of relief and to follow the way that guides. And in many ways, that can be very helpful. But you do have to detach yourself a little bit from that and ask, well, how do these models in my own qualitative assessment relate to the infectious disease problem as I see it? And I didn't get a sense of that happening, particularly from the public commentaries from TAC and particularly on 1 or 2 of their online published outputs.
So is the problem you describe perhaps less a TAG and TAC issue? Is it more a political one? Might it be said that, so one of the roles of, say, a Welsh minister, a non-expert in the field, is to receive the technical, the scientific advice, the modelling advice, and weigh that up against other kinds of impacts and harms? Would that be fair?
I think that's fair, and I think it's very fair to say that does the problem exist with the construction of the advice, its communication or its reception? And I think, frankly, problems can occur at any one of those stages.
We are going to hear later on this afternoon from Professor Michael Gravener. He was one of the modellers with TAG and TAC. And he explains in his witness statement that the problem wasn't with too little modelling per se, but with the fact that there was insufficient data and capacity to build sophisticated models accounting for, say, economic impact, social harms, indirect health harms, and so on, to be able to fully model the impact of MPIs. Have you got any comment on that statement?
I mean, only to say that that is true, and that is a common complaint that you hear.
Changing topic then and moving to population immunity, or as some refer to it, herd immunity. You have said in your statement at paragraph 16, just to sort of orientate you, you say, herd immunity is not a strategy, but rather a time-honoured epidemiological term that is used to characterise the resistance of a community to an infectious disease. Now, that statement is uncontentious, but perhaps you can explain to those following the evidence what you mean by that.
Yes. I think I mean to. I think that the quote that I've put in there describes it very clearly, and I'm not entirely sure how I can improve upon that. But I think it describes the circumstance where sufficient people have been exposed to a disease previously that new introductions of an infection can't get a hold and spread to any appreciable degree.
Now, as perhaps an important caveat, it's right, isn't it, that the notion of population immunity was built into modelling work that was done by SPI-M and SAGE. So it's not as though they ignored it altogether. They accounted for the fact that as community transmission figures grow, at some point people will develop immunity. So the virus peaks and case rates fall.
Yes, I mean, that is one of the ordinary underlying assumptions of what's called SIR modelling, which I think was the predominant form of modelling used both by SAGE and the TAC, though, as you point out, I wasn't there, so I can't say that with any certainty.
And likewise, by late February 2020, so when containment had ended in the UK, the scientific and policy approach was not that COVID could be suppressed indefinitely, which the knock-on effect of that is that almost every conceivable long-term strategy for tackling the pandemic would involve some form of herd immunity. Really, would you agree, the issue for the politicians and the decision-makers was what is the best way to get there?
Yes, I mean, I would go further than that. I think that was always the issue right from the outset. I mean, you provided me with Professor Whitty's statement to read as part of the evidence bundle, and he does a briefing note for the special advisor at number 10 Downing Street on I think it's the 28th of February 2020. And when I look at that, his summary of the situation and the possibilities, I have to say, is almost exactly the same kind of parameters of any summary that had I had to write one I would have come up with.
Moving on then, am I right in summarising your position in the following way, that the epidemiological notion of acquiring population immunity can be part of a policy of managing COVID-19 in a population as an alternative to the imposition of stringent population-wide NPIs? So that policy would be one of, I think you use the phrase focused protection of the most vulnerable to COVID-19.
Yes, I mean, I suppose the problem I have is that I consider the policy to represent what you would do either as a politician or a public health agency, and you don't do herd immunity. Herd immunity or population immunity is where you might get to, dependent on what the actual actions you take are. Now, the actions that were taken were rather stringent lockdown measures. My own view was that measures more focused on the individual would deliver a similar position eventually, which I think you're right to say that in both of them, the state of population immunity features is an important endpoint.
You say in your statement that acquiring population immunity is more of a beneficial byproduct of the strategy of focused protection.
Yes.
Is it perhaps not more accurate to say that population immunity and focused protection are really two sides of the same coin? So for those who are vulnerable, for them to return to a semblance of a normal life, the population around them needs to acquire a degree of immunity, thus enabling vulnerable individuals, we're obviously talking in a pre-vaccine world here, to receive healthcare, receive visitors, go into their communities and so on. Is that right?
I mean, I suppose I'd say you're welcome to make that distinction. It's not one I'd feel particularly necessary to make. I think the way that I've described as a byproduct probably has sufficient clarity for everybody's understanding.
Now, I just want to go through some of the concerns that have been expressed about this general approach, just to get your comments on them, please, Dr. Salmon. First, Professor Woolhouse, Professor of Infectious Disease Epidemiology at the University of Edinburgh, also a member of SPI-M, he has said in his statement to the inquiry in Module 2 that it was not known in the early stages of the pandemic whether the immunological resistance acquired from catching and recovering from COVID would be 100% effective in preventing reinfection. So just pausing there, this means that allowing the disease to move through the population in, say, March and April 2020 without any guarantee that previous infections would ensure immunity would be a highly risky strategy. Do you agree with that?
Well, actually, I don't. I mean, and interestingly, I think there are some contradictions in Professor Woolhouse's own witness statements in this. I mean, he makes the point that if you had taken more modest interventions somewhat earlier than they were, I mean, he uses it, calls it cocooning, I call it focused protection, then it would have been possible to detach the epidemics that were taking place among vulnerable populations in places like hospital and care homes from the wider transmission in the community. I think that's correct, and I think that transmission in the community might reasonably have been expected to bring with it a measure of protection. Now, you wouldn't have known how much until the epidemic had progressed, but I think you would have felt reasonably confident that you would have, while that was happening, be protecting the most vulnerable elements of society.
So do you take exception with me describing it as a highly risky strategy? Would you accept that it was a risky strategy then?
I mean, I think it would have been a relatively straightforward and safe strategy, and I think many of Professor Woolhouse's own comments tend in that direction.
And another concern, and do correct me if I'm wrong, with the approach of a protect vulnerable individuals while allowing population immunity for everyone else, is that does it not assume that population immunity could be reached within a matter of months or within a short period of time?
Well, no, it doesn't. I mean, it will take as long as it will take. I mean, I think the question you have to ask yourself are what are your alternatives given the disruption that other approaches will take? Yes, ideally you would hope it would arrive relatively quickly. I mean, there's an interesting historical example that I think Professor Heyman introduced at the very beginning of the proceedings of the inquiry, and that's the coronavirus OC43, which was almost certainly a pandemic virus at the end of the 19th century, yet certainly by the time we're able to identify it and study it, we think of it as a common cold virus, and it seems quite likely it transitioned to that stage in a relatively short space of time. So there were reasonable biological grounds for a degree of optimism about what would happen here.
Related to the point I just made about the population immunity might take a significant period of time, is a point that Sir Chris Whitty makes in his evidence in Module 2. His witness statement is at INQ 000248853, and we're looking at paragraph 6.23. Sir Chris says the biggest scientific weakness is that it starts from the thesis that inevitably herd immunity will be acquired if you leave things long enough. That is not the case for a very large proportion of the most important diseases in the world. For most of the major diseases I have worked on, you never acquire full herd immunity, basing a policy on the assumption that eventually immunity in the less at-risk population will protect the others is not a safe starting point. What do you say in response to
well, this is very like a comment he made in an interview in the BM British Medical Journal, and I frankly thought it was bizarre because your jumping off point And the examples he used in the British Medical Journal were the Ebola virus and the human immunodeficiency virus, HIV. Now, of course, your jumping off point for any consideration of your strategy is the biology of the virus that you're dealing with. And those viruses are so fundamentally different in their properties that, yes, of course, you wouldn't adopt a herd immunity strategy for them. But my point is that the underlying virology of the coronavirus is such that that becomes a reasonable option and, in my view, one that about which you could have made relatively optimistic predictions from a fairly early date.
There are a few other concerns that have been expressed with a focused protection policy. If I just outline a few of them so we can know your response, Dr. Salmon.
I'd be keen to respond, to be honest.
First, people who are not in the vulnerable group will contract COVID-19 and die. So this would happen at greater numbers due to a greater rate of transmission before, obviously we're talking before vaccine development. I mean, do you agree with that?
I'm not convinced about that either. I mean, what you're talking about is how do these different strategies work out in practice? Now, the strategies that we did adopt with the rather extensive lockdowns also, because I would argue of the loss of focus, also resulted in rather large casualty rates among the vulnerable in care homes and hospitals. Now, it's quite true that you'd have to craft your focus protection rather carefully, and it's also true that you might modify that as it goes along. But I don't see that intrinsically that would necessarily lead to more infection in a wider population. And indeed, it might lead to less infection of vulnerable people due to a point that I also make in my witness statement, that the number of severe cases is not merely, as John Edmonds erroneously said, a function of the number of cases. It's also a function of the time over which the virus circulates. The longer it circulates, the more opportunity it has to go into those risky situations like care homes, like prisons, like meat factories, like hospitals, where it will infect vulnerable people with the sorts of consequences that we've seen. So, as I say, I don't accept actually the point that Professor Whitty is making here.
Now, it may be that you will give the same answer to this next concern that you've just given, because another concern about focused protection is that hospitals would exceed capacity and not be able to provide other required forms of urgent care, let alone treating those that require assistance with COVID-19. Do you agree or disagree?
I mean, as I say, I think my previous answer substantially addresses that point.
What about, finally, the effect of focused protection on long COVID? That's entirely unknown and could be severe and significant.
Yes, I mean, long COVID is one of the unknowns in all of this. I mean, it's less unknown now than it was. And I can't claim I've looked at this in a lot of detail, but there were papers in The Lancet from an Oxford-based group based on millions of health records in the United States. And the takeaway message from that is not that long COVID is trivial or that we can discount it, not at all, but that it's very similar in both its frequency and in the range of symptoms to long forms of other viral and infectious diseases, which we know exist and which we coexist with. I have some knowledge of this because in the late 90s, with Dr. Sharon Parry of Cardiff University, we did a long paper for the Health and Safety Executive on the chronic sequelae, the chronic consequences of infectious diseases. So whilst I, as I say, fully acknowledge the uncertainties around long COVID, and I fully acknowledge its seriousness, it seems to me it's of a piece with other consequences from other infectious diseases about which we don't take similar protective measures. Now, we need to understand all of these a lot better, and if COVID gives a stimulus to research into this sort of thing, I feel that can only be a good thing. But what I don't think it calls for is particular extra preventive measures over and above those that are used for acute COVID, because the final point is that the worst, the most serious sequelae of long COVID appear to be proportional to the seriousness of the initial illness. So in as much as we control that initial illness and control its serious forms, whether by vaccination, whether by letting the vaccine circulate among people when they were younger and safer, rather than letting them get to being old and vulnerable, we will also be preventing the worst aspects of long COVID.
Dr. Salmon,
Are you moving on?
I am, my lady.
Could I just ask,
Please.
I don't know if it's easy to do in a few sentences, but could you give me some practical information on how focus protection would work? In other words, supposing my mother was still alive and living alone, I mean, how do you find the vulnerable? What measures do you put in place? How does it work?
Yes, sure. This was the kind of thing that I was trying to address when I wrote to a number of politicians here in Wales, and I'd like to commend the correspondence I have with Renat Yorworth to you. I mean, essentially, for the vulnerable population, it doesn't look terribly different from the lockdown that they had already. What is rather easier for them, however, is that services around them should be working rather better. I feel that on top of that shielding of those high-risk individuals, like your mother, for example, would be particular attention to the locations which we rapidly identified were a risk for spreading the disease. We've talked about these a lot: hospitals, care homes, prisons, meat factories. That is where I would have used test and trace, particularly when the numbers of tests available were rather limited. And there's a very simple reason for that. I mean, I've done my share, not as much as environmental health officers, of chasing people around the community and trying to actually manage a system of contact tracing in a wider community is extremely difficult and resource intensive. Whereas if you have a population for which you have a convenient register and you know who they are and you wish to stop the spread among them, whether that's staff of a care home, staff at a hospital, that is much easier to organise in an efficient and effective way, and actually eliminates the largest part of the problem. The final thing I would have done, and again I mentioned this in my letter, is promoted the use of protective equipment in at-risk occupations. And again, in the first 2 or 3 months of the epidemic, we were pretty clear what those occupations were. I mean, it is an abiding scandal that the PPE stocks have been depleted between 2009 and 2020. So that I hope that gives you a feeling for how I see this would work out in practice. And this was the suggestion, as I say, I made to several Welsh politicians. I mean, largely on the grounds that they were contemplating the fire break, which struck me as a thoroughly bad idea. But Mr. Poole may well wish to come on to that.
Dr. Salmon, let's just explore this then a bit further with you, because I think the letter you're referring to is the letter of 18th of October 2020.
Yes.
So we've got that displayed, INQ 000130868. Who did you send this letter to? I think you've said...
Oh, gosh.
Welsh ministers.
Yeah, it's...
I don't,
do you want me to run through the list?
I don't need an entire
Fine.
distribution list, but just give me a sense of who was in receipt.
I essentially sent it to politicians. I've had a long career in Wales, and Wales is not a big place, so I essentially sent it to politicians I had met under some other heading in the past. That was 2 Plaid Cymru politicians, Di Lloyd and Renat Yorworth, the Conservative leader Andrew R.T. Davies, and 3 Welsh ministers, Mark Drakeford, Vaughan Gethin and Julie Morgan.
Thank you. If we have a look, please, at the second paragraph, you list the matters that the letter concerns. Number 4, workable approaches centred on the person, targeted shielding, focused protection, which is what you've just been answering, my lady. If we go to that section then of the letter, I think it's page 2, you describe here how the framework would work in practice, and you suggest Roman 1, at-risk persons, at-risk locations, and then, thank you, and then over the page to the next page, at-risk occupations, which you've just alluded to. In terms of at-risk persons, you say effectively shield vulnerable people by a combination of advice to wear masks, avoid situations where they couldn't control their personal space, necessary social support to make this doable. Then, in terms of at-risk locations, the next bullet point, you say ramp up infection control, bring in regular screening and exclusion of infected symptomatic persons from locations where spread occurs readily. This would include hospitals, care homes, meat factories, prisons, universities. And I just want to focus in the time we've got on those 2 in particular, because it is known that the vast majority of deaths from COVID-19 in Wales occurred in hospitals and care homes. Some of those deaths in hospitals were, of course, contracted in the community, but we also know that rates of nosocomial infection were high throughout the pandemic. Professor Woolhouse has said about this, he says, it wasn't made clear how well the vulnerable segment could be protected from infection in practice. Now, the inquiry understands from February to March 2020, Public Health Wales and NHS Wales were devoting considerable effort to infection control measures, testing staff and patients, attempting cohort infectious and non-infectious patients and care home residents and so on. And yet still, Wales had a significant number of deaths amongst those who were being shielded. And that was a pattern that was seen across the whole of the UK. Now, against that backdrop, Professor Woolhouse's comment might seem like an understatement. What effective practical protections could have been provided to those who needed shield from March 2020 that were available in March 2020 that were not provided to vulnerable people in hospitals and care homes in Wales?
I mean, okay. I think shielding of vulnerable people at home, just to dispose of that first, was precisely the sorts of things that people were doing on their own initiative before the lockdowns were brought into place. A point, again, that I think Professor Woolhouse rightly makes. In terms of protection in the location, like hospitals and care homes, I'm not going to sit here and pretend there are any very easy solutions to this. I think would make the point that it didn't become any easier to do this because the whole of the population was locked down. In fact, quite the reverse. A degree of lack of focus, in my view, made spread in those particular locations occur more readily. I mean, the sort of things that you have to do, and having adequate personal protective equipment and having adequate capacity to test and trace, probably should have been anticipated on the basis of the pandemic flu plans, and yet apparently hadn't been. And yes, I think that I'll conclude there, perhaps.
I mean, would you agree that targeted shielding for social care workers in March would have been extremely difficult, would it not? You have a finite number of care workers. You have care homes that were not set up to enable isolation rooms and cohorting. And on top of that, you have a business model predicated on social care workers moving between sites.
I mean, all the above is true, but I think the question the inquiry might wish to ask itself is, did the introduction of lockdowns actually make that any easier to manage? And I would argue, no, it didn't. And that reminds me of the other point that, with advancing age, I'd forgotten. The other problem that we have is the lack of capacity in our acute hospital sector. Our hospitals run often at 85% to 90% occupancy all the time. With that, you really don't have the space and resilience for efficient and effective infection control. One way around that might have been to have used the Nightingale hospitals for step-down care rather than imagine that they would have been used for acute care. But as far as I can see, that never happened either.
There is one other matter I just want to ask you before we move on. Targeted shielding assumes that people who are vulnerable can be protected by virtue of their vulnerability, defined presumably as a health vulnerability. However, obviously the inquiry understands that those with pre-existing health vulnerabilities who are on the shielding list compared with vulnerabilities of whole communities are not necessarily one and the same thing. So, for example, we heard earlier this week from Professor Ogbonna and the findings of his socioeconomic subgroup that reported in June 2020, and they concluded that the risk of COVID-related death in males and females of black ethnicity was 1.9 times higher than those of white ethnicity, and that the risk of COVID-related death from men of Bangladeshi and Pakistani ethnicity was 1.8 times higher than white males. Now, I assume you are not proposing that Wales should or could lock down and shield communities that are already minoritised within society.
No, not at all. And I think a bit of context is quite helpful here, if you'll allow me. Easily the biggest driver of vulnerability is age. I mean, a point Professor Woolhouse makes and I endorse and comes from the original Open Safely study available on the 7th of May as a preprint 2020, is that the risk to an 80-year-old is 10,000 times the risk to a 20-year-old, the risk of death. Now, if you slightly, cheating slightly, put that into what is your year-on-year rise in risk, your risk goes up about 1.16 per year. So that means, of course, that someone from a black and minority ethnic group has the same risk as a white person about 5 years older than them when you sit and do the sums. So what that also tells us is that younger members of those communities, although they may be at more risk than their white equivalents, and this is quite wrong and shouldn't be the case, I entirely concede that, though they be at more risk, are not at substantial enough a risk that they need to change their behaviour patterns at all. It's just that the levels at which vulnerability kick in are at a younger age group in those communities, I say by about 5 years, based on some fairly crude maths.
Dr. Salmon, I want to change topic now, and you've anticipated that I might have wanted to ask you some questions about the fire break, which
Sure.
I'm going to do now. You described in your letter to the Welsh Government that we looked at a moment ago, and perhaps we can have it back up. It's INQ 000130868. If we can have a look at page 2, please, the first bullet point on that page. You say good adherence to measures is required. And the second bullet point, the incubation period of COVID-19, 2 to 14 days, combined with high asymptomatic carriage rates, circa 30% on young adults, ensures that the virus will be reintroduced into the community as soon as the circuit breaker is finished. And then finally, the third bullet point, if regulations and behaviour then return to pre-circuit break levels, there would be a return to exponential growth, meaning any respite is a very small number of weeks, too short to remedy problems with track and trace systems and too soon for vaccine to be available. I assume you stand by the concerns that you expressed at that time in that letter.
Yes, I do. And I mean, within the inverted commas are quotes from Sage Minutes that I'd taken from the Times. So in a sense, these are quotes from the proponents of this scheme that seem to me to suggest that it won't work, rather than anything that I may have introduced into the debate.
You say in your witness statement, from a simple eyeballing of the observed COVID incidents, it would be difficult to conclude other than any effect was marginal at best. So do you think that the matters that you've identified already, so especially, we've still got it on the screen, especially the second and third bullet points of the letter, prove to be borne out?
Yes.
Would those issues have appeared had the fire break been implemented for longer, in your view?
No, I don't think they would have been, because I think there would have been sufficient circulation in the community or sufficient opportunity for reintroduction that, yes, possibly we might have had a slightly longer pause, but exactly the same situation would have re-established itself very quickly. I understand the enthusiasm for some clinicians for the fire break. I mean, I am a doctor. I have worked, admittedly many years ago, in busy clinical settings when almost any respite is so welcome. But I do think this one was particularly expensively bought and really is hard to justify on broader social grounds.
Changing topic again slightly, talking about MPIs, at paragraph 24 of your statement, you say that you consider many decisions regarding MPIs that were made by the Welsh Government were, your words, inappropriate and lacking justification. You identify as 2 examples the Welsh Government's decision to close selected supermarket aisles and pubs being prohibited from selling alcohol. Can you just briefly explain why you consider those 2 examples to be inappropriate and unjustified?
Well, yes, because I can think of no basis on why you might think they would work. If we consider supermarket aisles, I mean, case control studies in France, the CONCOM study of the Institut Pasteur showed that large supermarkets and large department stores were not a setting where increased risk took place. So whether you leave the aisles open or you leave them shut really doesn't matter. And actually, if people are going into the supermarket, why do you want to shut one aisle and not the other one? It seemed quite... I mean, I think one of your witnesses yesterday was talking about a lack of lived experience, but that seemed to suggest a lack of lived experience of even going to the supermarket. And also, the pub with no beer, I mean, The problem with any setting, yes, restaurant and pub settings are an issue, are when people congregate in them, and those people who are vulnerable are best avoiding them and advised to do so. But sort of opening it up and not have beer seems to me perhaps an overly enduring legacy of the chapel heritage. I don't know.
Dr. Salmon, finally, you wrote a blog post titled "The View from Wales." We have it at INQ 0001308666. Perhaps we can just look at that together. If we can please have a look at page 2, the third paragraph, please, that starts finally. Grateful. Finally, the Wellbeing of Future Generations Act, some of Wales's most forward-thinking legislation, singularly failed to translate into any sort of systematic evaluation of the downsides of global lockdown approaches, downsides most likely to impact on just those future generations whose interests the Act seeks to protect. Please, can you just briefly expand on your views there on lockdowns in the context of the Wellbeing of Future Generations Act?
Yes, I mean, what I had in mind here was the loss of educational and employment opportunities to younger cohorts. I mean, children, students, young adults in work who bore a disproportionate share of the economic and social burden. And it's easy to think that, well, that's economics, and on the other hand, we're saving lives. But what I think we lose sight of, unless we take a whole life view of public health, is that those losses of opportunities and that economic loss will translate into, and there are plenty of examples of this, ill health and loss of life expectancy. It may not be as immediate, but it will certainly be there. Now, how we level those up, we're starting to stray into where people's values are, and I think where the politicians are reasonably expected to come in. But I did feel that this particular dimension wasn't even considered. And when I say I mean we, and if you'll forgive me, I might draw attention to who my fellow authors are. I mean, Marion Evans received the OBE for his work on SARS in Hong Kong in 2003 with the World Health Organization. Stephen Palmer had worked in Atlanta and set up the Communicable Disease Surveillance Centre in Wales. And John Watkins has spent his, I think has submitted written evidence to this inquiry, has spent his life working on influenza and respiratory disease epidemiology. So these are not lightweight opinions, whatever view you may take of mine.
Would you have supported a full lockdown if it permitted schools to remain open?
No, I don't think I would, because it has always been my view that the purpose of epidemiology is to target attention on those people who are vulnerable, who are at risk in the terminology, and those behaviours that constitute a risk. That is why you do it. And you do it in such a way as to keep the restrictions that you impose as targeted as possible and to allow as much of the ordinary life that people want to lead, whether you approve of it, whether you disapprove of it, to go on as much as possible. That is the whole scientific, not to say ethical basis of the discipline. So just to sort of think, well, this is hard work, well, let's just shut everything down, then that'll spare us any further thought on the matter, seems to me quite the wrong way to approach it. And I don't always agree with Professor Woolhouse, who I know distantly, but the title of his book, The Year the World Went Mad, is one I'm entirely in tune with.
Dr. Salmon, I have no further questions for you.
Thank you.
I don't think there are any
No,
routine
my lady,
questions.
there are no routines.
Thank you very much indeed for your help, Dr. Salmon.
My
Very
pleasure.
grateful. Right, well, just so everyone can make their plans, we have to finish by 4:15 at the latest, so should we break now for lunch
I think if we can, my lady, yes.
and then return at 1:30?
That's fine.
Thank you.
All right.